which antidepressants and mood stabilizers are best for women, and why you need to keep a tight grip on those Ambien doses. Join us as we highlight the minor and major differences between women and men. Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a Psych NP and a dedicated reader of every issue. In 1917, Sigmund Freud set out to solve the battle of the sexes. The idea he settled on, in his essay, The Taboo of Virginity, has outlasted most of his other theories. The narcissism of minor differences. The more two people have in common, the more they fixate on small distinctions, to feel superior, unique, and preserve their individuality. You see it in neighboring nations, in political factions, and for Freud, it explains so many marriages start on common ground and end in polar conflict.
So, before we get into the ways that medication responses differ between women and men, let's clear the air. First, in the spirit of transparency, Kellie and I got engaged last month. We started dating in 2020, a year after launching the podcast, and we're going to keep on podcasting after we tie the knot this August. But we also needed to clear the air about this narcissism of minor differences. While we're going to emphasize the differences between women and men in this podcast, let's keep in mind that women and men are more alike than different when it comes to psychiatry, psychology, and neurobiology. When researchers find a difference between male and female brains, it makes headlines. But these are usually chance findings, blips in a sea of similarities. When the findings of the past 30 years are pooled, as they were recently done in an analysis, sex explains only 1% of the variance in people's brain structure and neuroprocessing. That said, there are a few areas of psychopharmacology where a sex-specific approach pays off. We'll cover 14 of them in this 4-part series, starting today with valproate, zolpidem, and antidepressants. And we'll end with a peek at the upcoming DSM-6. Number 1. When to use and when to avoid valproate in women with bipolar.
There are 2 reasons to avoid valproate, Depakote, in women. In pregnancy, it harms the fetus. Outside of pregnancy, it disrupts female hormones. Valproate is the most teratogenic psychiatric medication we have. About 1 in 10 babies exposed to valproate in the room has a birth defect. The neural tube doesn't close, leaving the spinal cord exposed, or the skull fuses too early, causing dangerous pressure to build up as the brain grows. It can cause cleft palate, cardiac septal defects, and malformed limbs. Valproate also drops the child's IQ by roughly 10 points.
That IQ drop with valproate is from in utero exposure. Breastfeeding, though, is a different story. A controlled study of mothers with epilepsy compared those who took valproate and breastfed to those who chose to formula feed while they were taking valproate. 5 years later, the children who breastfed had higher IQs and healthier development. So it's not a randomized study, but fairly well controlled. Then it speaks to the well-established benefits of breastfeeding on development and IQ. And it's a reminder that a drug that is dangerous to a developing fetus isn't necessarily dangerous to a newborn whose organs have already formed. In newborns, we worry more about risks like sedation and respiratory depression. In the fetus, we worry more about organ formation.
The second reason to avoid valproate in women is hormonal. It raises androgens, testosterone and DHEA, leading to acne, male pattern baldness, weight gain, infertility, and a 2 to 6-fold increase in the odds of polycystic ovarian disease. Women who start valproate before age 20 are most vulnerable.
So while you should avoid valproate in women with bipolar, don't dismiss it entirely. Here are some reasons to prefer valproate in bipolar disorder. Along with quetiapine, valproate has the most robust evidence for anxiety in bipolar disorder. It works partly through the GABA system, similar to benzodiazepines, and it has positive trials in generalized anxiety disorder without bipolar, as well in anxiety due to bipolar. The second reason is that among mood stabilizers, valproate has the best evidence for bipolar disorder with alcohol use disorder. And here, it doesn't just ease the withdrawal problems from alcohol, but it also increases the rates of sobriety over time in bipolar. And if you're worried about valproate's liver effects, take heart. In that study, the liver outcomes were better on valproate because the patients were drinking less. The next reason is that valproate doesn't just treat mania in bipolar, it has several small but positive trials in bipolar depression. And last, compared to lithium, valproate has a slight advantage in bipolar with mixed features, though so do carbamazepine and the atypical antipsychotics, so you don't need to jump to valproate for that reason. And don't think black and white about this. Don't avoid lithium in mixed features. It can certainly work. This supposed superiority in mixed features with carbamazepine and valproate is debated, and no mood stabilizer has a clear edge in rapid cycling bipolar.
The bottom line, valproate is a last resort for women of childbearing age with bipolar disorder. If you do use it, counsel on contraception and add 4 milligrams a day of folic acid, or L-methylfolate 5 to 15 milligrams a day. That lowers the risk of problems in pregnancy and improves valproate's therapeutic effects in bipolar, both in mania and depression. Here's a peek at the CME quiz for this episode. Earn CME through the link in the show notes. 1. DSM-6 is planning to break up diagnoses into 4 components, including a separate Axis 4. A. Personality type. B. Biomarkers. C. Suicide risk. D. Medication response. Number 2. Keep zolpidem low in women.
In 2013, zolpidem, Ambien, became the first psychiatric medication with sex-specific dosing. The FDA lowered the maximum dose for women from 10 milligrams to 5 milligrams, or 6.25 milligrams for the controlled release formulation. The reason is slower clearance. Women metabolize zolpidem about 35% more slowly than men. Body mass accounts for some of this. About a third of the slowing here is due to body mass, but the bigger difference is testosterone. In men, testosterone accelerates the enzymes that break down alcohol and zolpidem, which is why women metabolize both of those drugs more slowly.
The FDA's guidance here is firm, and for good reason. Zolpidem only helps people fall asleep 10 to 20 minutes faster than placebo. It does nothing for sleep quality or mental health. At higher doses, it increases falls, complex sleep behaviors, things like cooking or driving in the middle of the night, and morning driving impairment. Put all that together, and it's hard to argue that the minimal benefits outweigh the risk, especially after a patient has injured themselves in an amnestic state, which is the only time we'd be called on to argue the point. Gender affects other Z hypnotics a little, but not enough to change the dosing for all women. Zaleplon and esoplaclone are cleared a little more slowly in women because of smaller body mass, but there's no enzyme difference as with zolpidem. Number 3. How SSRIs and MAOIs make a minor difference in women with depression.
Women respond better to MAOIs and SSRIs than to tricyclics in depression. One reason is that atypical depression is more common among women, the type with oversleeping, overeating, rejection sensitivity, and that heavy feeling in the limbs that we call leaden paralysis. Atypical depression responds better to these serotonergic agents, whether in women or men, and atypical depression is more common in women, especially before menopause. But this atypical depression thing doesn't fully explain the gender effects with SSRIs and MAOIs. Estrogen also plays a role. Estrogen influences serotonergic transmission, and both MAOIs and SSRIs depend on that monoamine for their effects.
The difference in responsiveness is real but modest, so let's stay grounded and not get all narcissistic about it. On the SSRI citalopram, women were 13% more likely to respond and 30% more likely to remit than men in the STAR-D trial. We see a similar female bias with MAOIs. For tricyclics, women are less likely to respond than men, while bupropion and SNRIs don't show a clear sex difference. After menopause, all these sex differences in antidepressant response disappear, either because atypical depression is less common after menopause or estrogen's influence is dampened.
Estrogen's interaction with serotonin also explains why some women have premenstrual dysphoria. Serotonin receptors become more sensitive when estrogen falls in the week or two before menses. Some women on an SSRI feel that the medication stops working during that period. And a common strategy is to double or raise the SSRI dose during those 2 weeks before menses. The same approach underlies the treatment of premenstrual dysphoric disorder, where the SSRI is only used for the luteal phase, the 2 weeks before menses. Fluoxetine became the first SSRI approved for premenstrual dysphoric disorder in 2000. Then it was sold under a new feminine brand, Serafem, no longer on the market. Sertraline and paroxetine soon followed with approvals of their own, but fluoxetine's long half-life makes it a good starting point if you're going to stop and start a medication. We'll cover premenstrual changes more next week.
A quick recap. Avoid valproate in women of childbearing age. It has androgenizing effects and is the only psychiatric medication absolutely contraindicated in pregnancy. Don't go above 5 milligrams or 6.25 milligrams with zolpidem in women. Just explain to your patient that you don't have a choice. It's a controlled substance and you're bound by the approved dosing. And if antidepressants aren't working in a woman with depression, especially with atypical symptoms, try an SSRI or MAOI. Today's study is an editorial by Niall Boyce in The Lancet that gives a preview of DSM-6, the first major revision since 2013. The APA has already formed the Strategic Committee. At the helm is Committee Chair Maria Oquendo, who chairs the Department of Psychiatry at the University of Pennsylvania and is known for her research on suicide, mood and anxiety disorders, ketamine, the serotonin system, and cultural psychiatry. Dr. Oquendo is the first woman to chair the DSM, and she is joined by Vice Chair Jonathan Alpert as Vice Chair. Dr. Alpert is a professor at Albert Einstein School of Medicine, and his work covers a broad swath from child to geriatrics, drug interactions to Tai Chi, mood disorders to culture and ethics.
First on the table is a name change, from the Diagnostic and Statistical Manual to the Diagnostic and Scientific Manual. You know, most psychiatric treatments are actually based on statistical outcomes, not biological science, rating scales. And that has led to some criticisms that we lack a scientific basis in pathophysiology, biomarkers, or even in mortality reduction when we think about our meds. So whether this name change is going to lead to substantive reform or not, well, that is the question. They're also proposing a 4-part diagnostic system. It's reminiscent of the 5 axes that we abandoned in DSM-5 that was used in DSM-4. Here are the 4 parts. First is contextual factors. These are the socioeconomic, cultural, and environmental determinants of health. Second, biomarkers and biological factors. Third, the psychiatric diagnosis itself, with levels of severity for each diagnosis. Fourth is transdiagnostic features. These are the non-specific symptoms that cut across multiple conditions, things like anxiety, social dysfunction, or cognitive impairments. Here's how this all might look in practice. I'll give a sample patient. For context, the patient is socially isolated, divorced white male, keeps the lights on at night, and rarely leaves the house. Biology. He has sleep apnea, vascular disease, and inflammatory markers. Diagnosis. Severe bipolar II depression with past alcohol use disorder in sustained remission. And transdiagnostic features. He has high anxiety and cognitive problems that aren't specific to any diagnosis.
I like this system. It lights up avenues of treatment that I might have missed if they were buried in the labs or social history. With this patient, I can see right away he's not likely to respond to medications unless his sleep apnea and social isolation are addressed. And the transdiagnostic axis lets me note the anxiety and cognitive problems without jumping to new diagnoses like generalized anxiety disorder or ADHD, which would only muddy the picture.
That's the idea here. The goal is personalized medicine away from fixed categorical diagnoses and toward individualized profiles that integrate symptom patterns, biomarkers, and environmental factors. It's kind of like the biopsychosocial model, just updated for our times.
The committee also hopes to make DSM-6 a living digital document, updated as new evidence emerges. A worthy goal, but we'll wait for the fine print. They said the same thing last time. If you want to learn more ways to personalize meds, check out our 2020 textbook, Prescribing Psychotropics. We've drawn on its gender chapter throughout this episode. The book has chapters on how to individualize medications and dosing based on age, ethnicity, genetics, diet, medical disorders, and drug interactions, including which formulation of carbamazepine to use and which form of bupropion to avoid.